So good afternoon, everyone, and welcome. My name is Melissa Mueller, and I am DWDC's Program Manager. And today I'm joined by my colleague, Kelsey Goforth, our Director of Programs. Before we begin, I want to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And we invite and encourage you to do your own research regarding the various treaties, in particular the land which you're meeting us on today. And I'm thrilled to welcome you today to another session of Focused Forum. Throughout this series, we aim to provide you with the information and key takeaways, as well as create a space for conversation on end-of-life topics and MAID alongside professionals that know it best. Before I welcome today's presenter, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit questions. To do so, please type your questions into the Zoom side panel, and we will read it out to you at the end. And please try to keep your questions as concise and clear as possible. While we are going to try to get to as many viewer questions today, unfortunately, we may not get to everyone. And so if you have an outstanding question following the webinar or questions that are quite personal in nature, please contact us at support@dyingwithdignity.ca, and we will follow up with you individually. And we will also be sending a post-webinar survey that will pop up on your screen after the webinar, and it will give you the opportunity to share your feedback. And this session will be recorded, so you will be able to watch it again later, so there's no need to take any notes. And I now want to introduce today's speaker. With us today is Dr. Stefanie Green. Dr. Green has spent 10 years in general practice and another 12 years working exclusively in maternity and newborn care before changing her focus in 2016 to medical assistance in dying. Dr. Green is the co-founder and current president of the Canadian Association of MAID Assessors and Providers, also referred to as CAMAP. She is a medical advisor to the BC Ministry of Health MAID Oversight Committee, moderator of CAMAP's National Online Forum, and has hosted several national conferences on the topic. Beyond her clinical practice, she frequently speaks about MAID to a wide range of audiences locally, nationally, and internationally. And she is a clinical faculty at the University of British Columbia and the University of Victoria, and most recently is the author of the best-selling book, This is Assisted Dying, and it is a memoir about her first year providing assisted dying in Canada. So thank you so much, Dr. Green, for joining us this afternoon. And I'm now going to pass it on to Kelsey to get us started.
Thanks, Melissa.
Thanks, Melissa, and welcome, Stefanie. So great to have you with us this afternoon.
Thanks, Kelsey.
So in your bio that Melissa just read out to us, she mentioned that you've been involved since 2016 in MAID, so very early days of MAID in Canada. What inspired you to get involved in this area of healthcare?
Sure, well, it's never a straight line, at least not with me. So I'd say, you know, I've always been interested in that intersection between medicine, ethics, and law. And for most of my career, as Melissa mentioned, I was in maternity care and women's health, and I was able to kind of fulfill that academic side of what I was interested in through that work. But at the same time, the notion, you know, I'm trained as a family doctor, and the notion of patient-centered care is kind of a pillar of family medicine, at least at the time I was taught, and I think in modern day medicine. And I like to think that I've always practiced in a way that honors that principle of care. Part of my other work actually is in infant circumcision. I think it's important there as well. But I was watching the Carter case come, the case that changed the law in Canada around assisted dying, and it seemed like a real culmination of the principle of patient autonomy and patient-centered care. And I was really drawn to that when I saw that happening, and I I really wondered who would do this care, who would step into that space. And I think the more I learned about it, the more I was drawn to it, the more it appealed to that sense of patient-centered care that I wanted to practice. And I got further and further into it. So not a straight line, but that's kind of how it happened.
Thanks for that. And over the last several years, working in the space and supporting people and their families during MAID and at end of life, how has that impacted you personally? Has that changed any of your attitudes, your beliefs, your values when it comes to end of life and MAID specifically?
Yeah, I think I would say, how could it not? How could it not affect me personally? How could it not have affected my practice and who I am? I think my attitudes towards MAID in particular haven't really changed. As I mentioned, I'm a very strong believer in the principles of patient autonomy. I am comfortable with the idea that our highest court has recognized that to prohibit assisted dying infringes on certain patients' rights. I'm very comfortable with that decision. That has not changed for me as I've practiced over the years. But what's really changed is me and my life and how I live it. And I think doing this work really is a privilege. It exposes me to some really extraordinary people going through extraordinary events, asking me to do, extraordinary things with them and to witness their journeys. And I've become much more reflective about what I see people going through and how I project myself into those situations. What would I do if I was there? Who would I want standing next to me if I was in that situation? Who are the important people in my life? And have I spoken with them recently? And that kind of reflective work, that kind of reflection of my work, kind of bringing it into my own life has been a transformation for me of some sort. And that's really what's changed the most. Not so much my principles and how I practice, but how I live my life as a doctor and I think as a person.
Yeah, absolutely. No, I hear you there, and working in this space and end of life, and you can't shy away from the conversations anymore. And we do live in a space, in a society that doesn't love to talk about death and dying all too often. So
it does not.
When you're in it, you're having those, conversations with yourself, with your loved ones, and reflecting on your own values and beliefs, which is, I think, really important.
Exactly.
So in your workspace, and again in the bio that Melissa read out to us earlier, she mentioned that you worked in family practice for a number of years, switched gears, and do a lot of work in MAID and end of life space. How much of your work time or your general time is spent in supporting people with MAID? Is that the biggest chunk of your work, or?
It is. I'm a little bit. Well, I was just about to say I'm a little bit odd that way, though I'm not so odd, I don't think. I am trained as a family doc. I don't do general practice anymore. I mentioned I still do some circumcisions that grew out of my maternity practice. I do that one day a week, but all my other work, all my other clinical work is now associated with assisted dying. The amount of actual clinical hands-on patient care goes up and down during the year, depending on all my responsibilities in different ways. But yeah, 90% of my clinical work is now spent in assisted dying. And I think in the beginning, when I started to do that, I did that from the very beginning. I think I felt like a little bit of an outlier that way. Most people were providing MAID care kind of on the side of their other practice. They might have a full family practice and do MAID for their own patients. They might have a full practice and do it on the weekends or the evenings. They might be a specialist of some sort and just want to support their patients. I do think we've seen more people nearing the end of their careers, almost in their retirement years, turning more towards, leaving that major practice, but still doing MAID work. And so there are, I think, a few more people out there now whose primary clinical effort is in MAID because they find it meaningful work. We find it, I find it very meaningful work. And I think as people regulate how much work they can and can't do, they're picking and choosing which parts they want to do. And I'm glad to see that that's happening. On the other hand, I'm a little bit worried that my colleagues are going to be retiring very soon, and there may be less of us doing this work if most people are kind of at that stage. So for me personally, it is 90% of what I do. As Melissa mentioned, I do run CAMAP, the Canadian Association of MAID Assessors and Providers. That takes quite a bit of my volunteer time, and there's lots of work going on there that keeps me busy as well. but it's all assisted dying related.
Thank you. So we've all collectively gone through a lot over the last several years with the COVID pandemic and continue to be affected by that quite a bit in our daily lives. So I imagine, like a lot of clinicians and a lot of MAID assessors and providers, there was a bit of a shift in how you approached your MAID work and your MAID support, mainly doing maybe assessments through online mechanisms rather than in person when in person wasn't as possible. Are there any other impacts that you've noticed over the last couple of years on MAID access in relation to COVID?
Yeah, I think, I mean, you've hit the number one. The number one is that we're now, I'm able to do some of my work through virtual means online with Zoom or other, secure platforms. To interact with patients that way has been really very convenient for some people and really accessible for people who it might not have been accessible to. That the rise of virtual care, not just in MAID work, but in healthcare in general, has been a really big, I think, change since COVID, and maybe one of the only silver linings. So that's been interesting, but that's still a challenge, right? Some patients, some people can't use that technology. They either don't have it, or it's too complicated, or they're ill, right? Their hearing is not so good, their sight is not so good, the ability to use the camera is not so good. They maybe need someone to help them. So it's still less than ideal. So I struggle with still getting back to in person. I do that as much as possible. I think there's probably two other things though that I've seen COVID has really changed in the way that I work. One of them is a little bit abstract, but you won't be surprised to hear that, I think the COVID pandemic really highlighted some of the problems in our healthcare system and where the deficits and the gaps are. And maybe it was always there before, but I've certainly heard more people expressing the idea that they're not as willing to go to long-term care placement. They're not as eager to stay in long-term care. They're not satisfied all the time with that option. And I think it's changed some people's focus on what's important to them, what's most meaningful to them, what is and isn't acceptable, whether they're heading that way or whether they're already in it. And that's a much more expressed thought than I think I heard before. And that's not great. It's not great to hear. It's really exposing a problem and a gap in our system that needs to be addressed. And I guess the other thing is that certainly before COVID, and as much as we can now, but MAID is a very intimate event. When the actual scheduled death is happening, it's usually a small group of very important people in the patient's life who are in close, who are, expressing their love and their loss and their, what they need to say. It's usually a very intimate event and a very, very important event, and really in close quarters. When COVID is present, that's difficult to do and stay safe at the same time. So the nature of how we choreograph that event and how we allow people to interact has changed and comes and goes depending on the pandemic. There were certainly times when I started giving instructions to families and patients, from 6 feet away out on a patio on the deck, instead of inside in the living room or in the bedroom, trying, sometimes with a mask and a face shield on, or even a gown at some time. So it takes the intimacy out of that final moment, and trying to find the balance between protecting ourselves, our team, the family members, and also still allowing that really important time at the end, which, you only have one shot at. Finding that balance has been a challenge. Patients ask me, can I take my mask off? It's of course you can. This is your spouse of 50 years. Of course you can take your, I'm not going to interfere with that. And at the same time, I need to be conscious of protecting my team and myself. So I think that final moment has changed. We're still challenged with that.
Yeah, absolutely. Sort of prior to COVID, I feel like that was never, it just was never at the top of anyone's mind. It was so, no one really saw that coming and those challenges, and then having to pivot and adapt and, like you said, do what you can to ensure safety as much as possible, but maintain the, just
respect for that situation.
Exactly.
It's
Yeah.
important.
Yeah, very difficult.
Yeah.
So I'd love to get into a little bit more about your experience as a provider, and
Sure.
and I'm sure many of our folks on the call today have read your book and read about some of the experiences that you've had. And I think with lots of areas of medicine and healthcare, there's amazing, rewarding parts. There's also challenges. So I'd love to talk a bit more about that and hear a bit about what is the most challenging part of supporting people through MAID.
I think it's changing. I think there's 2 or 3 things that are, all of them are the most challenging. Certainly telling a person who's come to me and asked for help, certainly telling them that they're not eligible for whatever reason, is right up there as one of the most challenging things I do. I mean, that anybody who comes, by the time they come to my office and sit in front of me, or I go to their home to speak to them, they are asking for help to end their life. They believe that they are suffering intolerably. They are really struggling. And so this is someone who's vulnerable and someone who's really in need. And so for me to hear their story and interact with them and then have to tell them, I don't disbelieve you. I take at face value what you're saying, but the law is written in such a way that I can't help you in this situation. That's tough news to deliver. That's hard for me to say. It's hard for people to hear. It's not always easy to understand. I try to explain why I believe that. I try to offer other resources or other paths or other things that they could do. But I leave those interactions feeling sad, feeling challenged, feeling uncomfortable at times. Not uncomfortable enough that I'm going to break the law and change my mind, but I find those extremely challenging moments. I think the other thing that I had found really challenging, which I mention actually in my book, which has gotten a little bit better recently since 2021, since the amendments in our law since C7, and it still does happen when I've been working with a patient and a family and we've gone through the assessment and I've told them they're eligible and that we've planned an assisted death. And then I show up to offer the care and they are unconscious or unable to consent to go forward. And that's really, really tough if that was unanticipated or we didn't see, it was really, really unexpected. Because if it wasn't expected, we may not have planned for that situation. And if I don't have the ability to get their consent in that situation, I can't go ahead. I know that's what they wanted. I know that's what the family has agreed to. We're all gathered there to do that. But unless I have consent, I can't. And that's extremely, extremely difficult, very uncomfortable for me. I think that's probably the hardest situation I've ever been in. And again, needing to walk away and offer other resources and other options in that situation. Very, very difficult. We do have some ability to deal with that situation now. If we think that might be possible, we have now these waivers of final consent where patients and providers, if they see that this might be a possibility, that we can enter an agreement beforehand such that if that happens, we can still go ahead. But it does still require that we think of it and that we plan for that and then we enter that written agreement. So that's gotten a little bit better, but not always. And I guess the third thing that's really challenging is new now since 2021, and we certainly see in the newspaper, it's challenging to do my job properly when there aren't adequate resources for my patients. So if patients come to me and have chronic conditions that require real specialty care, complex chronic conditions that require expertise and input that I may not have, it's not always easy to get those resources and in a timely fashion. And part of the law is for me to find those resources, to offer those resources, to make sure the patient has been offered those resources, to give serious consideration to those resources. It's hard to do if I don't have anything to offer. And I find that really, really challenging in this day and age when the healthcare system is really, really breaking down. And it was hard before, it's harder now. So these are really big challenges in the work. I think those are the three biggest.
Yeah, and I think you speak to something that I think there might be some misconceptions out there about just how in-depth assessments are and how much of that trying to find other resources, trying to connect people with other supports happens from the assessor provider point of view, and how that can be a challenge sometimes to find, what exists in the community.
It is a very rigorous system. It's not, you can't just call up and ask for an assisted death. There's lots of eligibility criteria. All of them have to be met. There's procedural safeguards. All of them have to be met. Two clinicians need to agree that all of those things have been met. It takes time. It takes effort. It takes exploring other options. It takes discussing those with patients. It's a very rigorous system. So I think it's rigorous for the patient, and it's unfortunate, but it has to be that way. That's the safeguarded system we work in. And it can be challenging to the clinician to ensure that's done properly, but we all do our best.
So on the other side of this question, I wanted to talk a bit about what's rewarding, and you talked a bit about just the profound experiences that you're in, with the person, with their family. Can you share a little bit more about why do you continue to do this work after the last several years? Why is this something that you commit so much of your time to as a doctor?
It's a great question. The optics of answering that question are always a little bit tricky because of what I do and because of the nature of the work. It sounds a little flippant to say it's great work. Can't really put it that way. But the work has proven to be very, very meaningful work. When I've said this before, you may have heard me say, when someone has been through that really rigorous process, and I do sit down in front of them and say, you're eligible for this care. It doesn't mean you're going to have an assisted death. Doesn't mean you have to have an assisted death. You can just think about that or never have one. But regardless of that, you may, because all the tick boxes are done, all the eligibility criteria have been met. When I can empower someone with that possibility, with that decision, it's really remarkable to see what happens in that moment. Almost every time that I say those words, you are eligible, I see an actual transformation in the patient. It's physical. I see it objectively. I see their shoulders relax. I see their head begin to nod. They often will smile. They will almost immediately offer their gratitude for the possibility for my work to get them there. It's remarkable how they stop thinking about how they're going to die. There's been a lot of thinking about how they're going to die and what they think that might look like and their fears of that. Even if we've talked through what that could or couldn't look like, at that moment, they stop thinking about how they're going to die. And they almost always start thinking about how they're going to live the rest of the time they have left in their life. And it's a radical shift. And it's very therapeutic. I see that by just doing that, I have made a difference in this patient's life and probably in that of their family. And I find that tremendously rewarding, even if I don't actually ever provide the assisted death. And then when and if this goes on, when and if they do schedule their death, and if I show up to do that and I follow through and offer them this assisted death, I really feel like I am ending someone's suffering. I feel like in the moment I'm doing that, I feel like I'm allowing closure for this family to have this time together, to say goodbye, to say the things that are important. I think that it's just, it's very moving to see families and patients go through this together. I mean, it's sad. It's always sad. Someone's life is ending, but it's also often beautiful in a way, where people can have this closure and that control at the end. So I think the work is, the work of a clinician, of a physician, people often will think, well, doctors' jobs are to save lives and cure diseases and extend life at all cost. And it's really nice when we can do those things, and we all try to do those, but that's not the bulk of what physicians do, at least not family physicians. I mean, we see people at all stages of life in very vulnerable positions, and what we do is we help people, right? They come to us when they need help. And that's that old expression, that classic expression, we cure sometimes, we care often, and we comfort always. That's our role. Why do I do this? Because that's like asking me, why am I a doctor? I do this because I'm a doctor and I help people. And this is part of helping people. They've come to me at a specific stage in life when they need my help. And I think that if I'm in a position to help them, then I'm honored to do so.
Yeah, that was beautifully put. And I feel like that I wish, more clinicians could look at MAID the way you did just now. And, it's a part of the caring, it's a part of the comforting, it's just a part of what you're here to do as clinicians. And yeah, that was really great. Thank you. And I think this leads nicely into the next question, which is when you're reflecting on, being in the room with somebody and it's sad, they're dying, there's grief, it's happening, that will continue to happen after that person is gone. And there's, we can't downplay the pain people are going to experience because they've lost somebody has died. But there's also that beauty and that special and kind of unique opportunity to really create ceremony, create some way to honor that person and who they are and what matters to them. So do you have any examples or anything that stands out to you when it comes to ceremony at end of life and what people have chosen to do?
There's so many that stand out. I mean, it's really, I did birth. Births are all different, even though we kind of know the pathway and what's going to happen at the end. There's going to be a baby in your arms. They're all unique, and deaths are all the same. They're also not the same. They're all unique. What's the same is that they're unique. So there's a lot of standouts. And in terms of ceremony or ritual, I've seen everything from elaborate ceremony and ritual to very, very simple, something that someone might not even, describe as ceremony and ritual, but it still is. So, one of the first ones that stood out to me was is that of John Shields, and there's a fantastic New York Times article about this gentleman. He was in the early days in 2017, and John was a very remarkable man, and he was a very spiritual man, a religious man originally. He was a priest. He left the priesthood, but he remained a very, very spiritual man throughout his life. And you can read about him and his story, but he really showed me the essence of what kind of ceremony can be involved. John created a living wake for himself. He organized a living wake for himself the night before his assisted death, and he, like a real Irish wake, where people would come and tell stories and jokes and roast him and toast him, and friends from work and friends from family. He hosted his own Irish wake, and that in itself was a ritual, I think. But the next day, for his actual death, here's this man who's very spiritual, who's no longer, who's no longer in the church, but he actually worked with an officiant for this ceremony. He kind of had someone come and call on the spirits and call on the ancestors and give thanks to the things that were important for him. And he incorporated prayer, and he incorporated spirituality, and he incorporated indigeneity, and all kinds of elements that were kind of invoked during his death. It was a beautiful ceremony. That's exactly what it was. And so I that kind of expression at the end of life is incredibly meaningful to the person and to their entire family, to the people who are there with him. I've seen much smaller versions of that. The one that always stands out. It's easy to say this woman wanted a poem recited. She wanted someone to read a particular poem, but her two sons were with her. It was just me, the two sons, and her, and she was very ill and in hospital. And I'm sure one of her sons must be in theater or something. He read that poem. He didn't read it. He performed the poem. He sat on the edge of her bed and he performed this rather long poem, and he and his brother kind of did it back and forth. And she was lying there with her eyes closed, reciting her favorite parts, like mouthing them to herself. Obviously a very, very important poem to her. And it was this beautiful, almost dramatic event between the three of them. I don't know that someone would call that a ceremony, but for me it was. It was a real ceremony for them. And I find it's interesting at times. I live in British Columbia, where there's definitely a decrease in organized religion in most people. A lot of people do not, where I live, do not kind of feel connected to organized religion, but there's a lot of spirituality out here. And what we're seeing is these really creative efforts to create ceremony and ritual around these major life events like death that aren't the standard ones. So I do see people who have prayer and who have ministers and priests and rabbis and imams and kind of the organized, what we expect, but also all these interesting creative ways of expressing themselves and what's important and what's ritual to them. It's fascinating to see what people come up with. You've probably seen the recent video commercial from out of Quebec. There's a story of this young woman who who's on the beach in British Columbia and creates this beautiful ceremony for her, what's important. And it reminds me of that. Lots of ceremony out there. Yeah.
Yeah, absolutely. And what stands out, and I know this isn't consistent for everybody, but what stands out from some of the stories you just shared is, the involvement of family or friends and the wake and the poem reading. And, there's people involved who love and respect the person who's having MAID and seem at least to be supportive of what they're deciding to do. Have you had situations where loved ones were not as supportive and maybe not as willing to be as involved in those final days, weeks, moments of the person's life? And how did you support the patient and the family through that?
Yeah, that's always extremely challenging. And I find it, I mean, personally, professionally, I find it quite sad. I think everyone deserves to be held and supported, especially at a time like this. But it is what it is. People have their families and their dynamics, and situations aren't always, as someone said, champagne and strawberries. Luckily, it's not so common, but I've certainly had my share of families that have not been so supportive. And from a professional point of view, as a clinician, my goal is always to try to smooth that over if I can beforehand, not to just accept that they won't be supportive. It's not my place to interfere in a family dynamic, but it is my place to try to figure out why there is this dynamic and if it can be improved upon for the patient, because it can be very meaningful. So, I always try to speak with the patient about why this situation exists or why they believe it exists, and find out whether they're willing to have to be part of a respectful dialogue with someone who maybe disagrees or seems to disagree with them. And I find it's very powerful when the patient themselves, if they're capable, to express what they want and why it's meaningful to them in a setting that is kind of facilitated. Sometimes people just yell at each other. So sometimes if people agree to come to the table together to just respectfully listen to each other, not promise to agree, but just hear each other out, it can be quite powerful. And when they maybe the first time they've heard someone express what they're going through and what they need and why they need it, can maybe not shift agreement, but at least build some respect. And the same with the other direction. Instead of just being, well, they don't want to listen to me and they don't respect me, sometimes they, the family or the loved one can express what their worries are, what their concerns are, why they're upset. And listening to each other is so important. I mean, quite honestly, it's something we're missing in education and politics these days, everywhere we look. I think respectful dialogue is a really great starting point. So I always try to create that. And if I don't have the talents or the skills to facilitate that myself, I will get professionals. I will ask counselors to come and see if we can create that situation. I think it's important to give it a good shot. But in the end, it's also important to know that our law is written in just a way that, we understand what is and isn't required. We understand that the patient has the right to make this request, that the patient has the right to have it the way that they need it to be, assuming they meet the criteria. The patient is not required to inform their family. It would be best if they did. It would be ideal if they did. I would like very much if they would, but they don't have to. And as a clinician, if a patient says to me, you may not tell my wife, brother, spouse, child, I cannot, or I will lose my license, right? So it has to be respected. We have a court case in Nova Scotia that actually has this tested through the courts. We know the courts agree that the family cannot interfere. They cannot delay or interfere in accessing MAID. The courts have no role in determining eligibility. We have that set out through the courts and through our guidance and through our legislation. So ultimately, I'm taking my guidance from the patient, but I will do my best always to involve family if it's at all possible. I mean, it's very uncomfortable when people yell at me and say things that are mean, and it's difficult professionally if they come at me and try to complain about my professional duty. That's even if I know that I'm right, I don't want that to happen. Yeah,
absolutely. So you've mentioned earlier in our discussion today, you were talking a bit about how how your MAID work is formatted in your life, and you spend a lot of time on MAID focused work and mainly actually supporting patients with assessments and provisions of MAID, and also spoke a bit about how a lot of your colleagues in the MAID space are kind of doing this in their retirement or getting close to retirement age. And I think it's been so helpful for you and others in the space who have been very outspoken about your involvement in MAID and have shared honestly what it's like to be a MAID provider, through your book and through other providers doing public talks and interviews and things like that. I think that's been just helpful for everyone to get that clear understanding of what this role is and what it means to be a MAID provider. So if we have any physicians or nurse practitioners joining us today or who watch this later on, is there anything that you would say to those folks who might be considering getting involved with MAID, considering becoming an assessor or provider?
I would say, please do. We need you. I would really encourage anyone who's even remotely curious to learn a little bit more about MAID. I think that it's important that clinicians know that they already possess all the skills that are required to do this work. It's not that you require another residency or fancy surgical training. Obviously, there's training and available and education that's available that I would certainly encourage. But the basic skill set to do this work is part of what we do already. Assessing capacity, assessing coercion. These are things we do all the time, every day, with every patient interaction. So it shouldn't be daunting in terms of the skill set. It would make a tremendous difference to the Canadian public if clinicians, especially primary care clinicians, would be willing to support their own patient population. So if you are a family practitioner and you might have one, maybe two patients a year who are contemplating this, if you could be that support person for them, if you could answer their questions even in a way that was well educated about MAID, if you could refer them to better resources, or better yet, be that person who can be involved in their assessment to see if they're qualified for MAID, it will make a tremendous impact on the programs which are struggling, which we don't have enough clinicians to do this. It's very meaningful for your patients who feel very connected to you. You've supported them through the last 10 years, let's say. It would make their situation better than anyone else. It would make a tremendous difference to the patient, to the program, to the general public to do this work. And you do have the skill set to do it. I think the other thing I would mention to anyone who's even remotely interested in doing this work is that you're not alone. You're never alone in this work. We've worked very hard in this country to make sure that anybody who's interested in doing this work or stepping up doesn't do this in isolation. I purposely, my colleagues and I, we do this transparently. We do this in the open. This is legal, medical, covered, available care in this country. Like any other element of healthcare, it should be done in the open with our colleagues, learning together. How you learn is always, the same thing, from training programs, from colleagues, through mentorship, through preceptorship. You're not alone. There's a national organization that supports the people that do this work in any way that we can. There's a community of practice available where you can connect with people that do this work and ask any question and be mentored by that. So I would say, if you're curious about it, please find out. Please support your patients. Please do the training. Check it out. See if it's interesting. You'll find when you connect with others that it is meaningful work, and I think you won't regret it if you step into the space.
Thank you. So we're going to do a little bit about looking ahead. Are there any, and I think you've touched on quite a bit of this throughout our time together this afternoon, but are there any improvements you'd like to see when it comes to MAID and how MAID is operating in Canada, other than getting more physicians and nurse practitioners involved? Is there anything else that you can think of that would make the process more patient friendly?
Well, I think the first thing that comes to mind is one of the most important barriers that still exists out there. And I think that is the fact that there are still some facilities in this country that have objected to providing this care to the patient population. I think that That's a real disservice to both patients, their families, and clinicians. And I'm not actually sure that's even legal, but maybe that'll be challenged one day. But I see that that's a significant problem for patients who don't always get to choose what facility they're in or where they go. They might have been taken there by an ambulance. They might have been placed there because it's the best facility for their particular problem. It may or may not be faith-based. It may or may not be a palliative facility. It may just be a facility that doesn't know about MAID or doesn't want to know about MAID. It's not really fair for a taxpayer-funded facility to just say, well, we don't offer this care. This, as I said, this is legal, available, fully covered medical care in this country. So I think, when facilities don't allow assessments for MAID on site, when they necessitate that patients need to be moved from them in order to go somewhere else to get either an assessment or a provision of MAID, I think that's very obstructive. I think it's rather cruel to the patient and the family. And I think there's a notion, I really understand and respect the notion of conscientious objection. I get that. I fully respect that. No clinician should ever be forced to do this work. Absolutely not. I'm not sure that buildings, brick and mortar can do that, but I do know that clinicians sometimes purposefully and conscientiously want to participate in care. It's kind of the other side that we don't talk about as much. And clinicians and nurses and caregivers in some of those facilities want very much to care for their patients and to be involved in their care and to allow them these assessments and to be there with them to facilitate their provisions. And they're not being allowed to do that because of an administrative decision, which I think needs to be challenged, to be honest. So I think that's something I'd like to see change over time in this country. And I think patients will demand that. That's how things have changed in this country. That's how our law changed. That's how law continues to evolve on the backs of patients whose rights are being infringed. And I think it's not really fair for it to happen that way, but this might continue to be the way that it happens going forward. So I'd like to see that change.
Yeah, absolutely. It's been, there's just consistently been those stories over the years of people being forced out of hospitals and, at the very end of their life when they're moving them to a different room seems just, why would you do that to someone who's at end of life, let alone in an ambulance across town? It's just really, really unfair. So I agree with you. That's certainly a priority and something that we'd like to see changed as well. So I'm going to open it up now to some audience questions, and Melissa has been active in the chat, typing individually to some of you and also adding some of your questions to our list here. And we also got a number of questions ahead of time that we pulled from our registration list. So I'll be doing a bit of a mix of those. And if anybody has more questions, feel free to put them in the chat. We'll be here for a little bit longer. So somebody is saying that they're an end-of-life doula, and they're wondering what, in your experience, what role have end-of-life doulas played in supporting people through MAID? Is that something that you've seen more of, or any comments on their role?
Yeah, I appreciate the question. I think it's a really important role. Personally, I've had limited experience with end-of-life doulas, a little bit, but not as much as some others. I think maybe just because of the area that I'm working in. But I think there's a tremendous role for end-of-life doulas because families often need that extra support. I'm sure the person who asked the question could probably answer their role better than I can explain, but end-of-life doulas support the family, support the patient and the family as they're going through the process. They can advocate for them when the system is difficult to navigate. They can be more present. Sometimes some clinicians can't be present as much as they would wish because of their other jobs and their other work. We show up when we need to show up and we do as much as we can, but having that doula, just like in birth, can often fill an extra space to support the emotions that are happening, to direct to resources, to help find bereavement and grief resources before, during, and after. I think there's a really strong role for doulas to get involved. And it's true that some families maybe don't want that or don't appreciate that, but I think that a lot of families do. It's a little bit like at birth, right? Some people want birthing doulas and other people don't want that. So it's very, very similar role in that sense. but they're very welcome in the space. Let me just say, clinicians welcome you in the space. You're welcome to the national community. I think it's great that we're seeing this happen.
Great, thank you. So we are getting some questions from folks who are wondering, when MAID will be permitted in their province. So just taking the moment to clarify that we do have assisted dying law that applies nationally. So it is available for you in your province if you're eligible. And some follow-up questions coming through in a similar vein about how to access MAID and how to get connected with the appropriate people in your area. So most provinces do have either a provincial or regional care coordination service. And we do have a list of those by province on our website. So you're welcome to find those on the website. And if you do run into issues and you can't find the page or just need some additional navigation, you're welcome to email us at support@dyingwithdignity.ca so we can provide additional info. Oh, Melissa just put it in the chat there. So we're getting some questions as well, Stephanie, just people asking what changed with C7 and how are we in a different position than we were prior to C7? What did that mean for access to MAID, and what types of medical conditions are now maybe causing people to be eligible when they weren't prior to C7?
Great. I love an audience that wants to understand well. That's great. So I'm going to take 2 or 3 minutes to just answer that. I'm going to talk about what the law originally was and then what changed and what that means. So we had a Supreme Court decision in this country that struck down what was before a blanket prohibition of assisted dying. They outlined a couple of circumstances that needed, that should be true. But basically, from on high, from the Supreme Court, it was no longer illegal to provide assisted dying in certain circumstances. So the government decided to regulate this practice and create a law. They legislated this, and they created what we generally call Bill C-14 or C-14, the original law that regulated MAID in Canada. And that's what came in June of 2016. And in order to access an assisted death in 2016, you needed 6 things basically to be true. You needed to be over 18 years of age. You need to be eligible for Canadian government-funded healthcare, so all your provincial, OHIP programs. You need to make a voluntary request for MAID, so nobody's encouraging you or pushing you into it. There can be no sense of coercion. It has to be voluntary. Only you can ask for it. You need to have the capacity to ask for it, meaning you're able to understand what it means that you're asking for. You understand what's wrong with you. You understand your illness, your treatment options, your other options, including palliative care, the risks and benefits of those, and understanding and appreciating that if you have an assisted death, you will die, and that's irreversible, and that you still articulate your request to die, that you make an informed consent. You have the capacity to understand and to give informed consent. And the last thing that needed to be true is that you need to have what the law called a grievous and irremediable condition, meaning you have a serious and incurable illness. But the actual definition of a grievous and irremediable condition is actually written into the criminal code of our country. And I'm going to tell you what it originally said, and that's what changed, essentially, with C7 in 2021. So the original definition of grievous and irremediable condition was that you had a serious illness, disease, or disability that puts you in what they called an advanced state of decline, or that you're no longer functioning in the way that you used to because of your illness, disease, or disability, and not in a small way, but in an advanced way. So a serious illness that puts you in a state of decline, a serious advanced state of decline, that you're suffering intolerably, that you can't endure that anymore, that you, the person, believes you're suffering intolerably. And originally, no longer now, but originally, you also had to have what they called a reasonably foreseeable natural death. Not that you were dying in any particular time frame, but that you were on a trajectory towards death due to your medical condition, your overall condition, and that it was either happening sometime soonish or that it was very predictable. There's different ways to talk about what that means. But that was contested. That element, that extra criteria of having a reasonably foreseeable death was challenged in the courts. And essentially what happened in 2021 when C7 came in, they amended the law. And 2 or 3 significant things happened. Number one, that criteria for a reasonably foreseeable death was lifted out of the law. It's no longer required. And that meant that patients who aren't on that clear trajectory towards death, who are not dying very soon or maybe have a predictable course of death, they could also access assisted dying now. And who is that? We're going to see what the national data shows, but for example, that might be someone with a long-standing chronic complex disease, chronic pain syndromes, chronic neurologic syndromes, chronic genetic problems, a variety of things. So usually complex and complex scenarios, as opposed to those whose death is reasonably foreseeable. They might be someone with metastatic cancer who's dying relatively soon. The law created these two paths to MAID after C7 in 2021. So the two paths decide which safeguards need to be met. After you meet all the eligibility criteria, there's certain safeguards that still need to be met. Things that might be as straightforward as making a written request, having it signed and dated, and giving consent. If your death is reasonably foreseeable, those are the types of safeguards. But if your death is not reasonably foreseeable, now allowed, there's more safeguards. So all those same ones, you still need to make a written request that's signed and dated and give consent, but you also need to be shown the other resources that are available to reduce your suffering, to consider them seriously, to be offered those, to bring in expertise on the condition. So there's extra safeguards that need to be met. And that's the real difference that's happened in C7. And that's why we're seeing lots of news stories about different types of patients now, trying to access MAID, and whether they can or they can't, and whether they can access these resources or not. That's the real difference. Reasonably foreseeable was lifted out. New safeguards were put in for patients whose death is not reasonably foreseeable. And of course, C7 also made explicit that people whose mental health disorder is their sole and only underlying condition, that temporarily, until March of 2023, they're not able to access MAID, but in March of 2023, they will be able to. So that's a very long-winded answer. I don't know if it was clear enough, but that gives a sense of the significant change.
Yeah, no, absolutely. No, I think that was great, Stefanie. And I mean, we've had a lot happen in the last number of years, and sometimes there is that confusion about what's the actual difference and what's the difference in practice between C14 and C7. So I think that background was really helpful. One follow-up to that, in your own MAID work, what's the breakdown that you're seeing between individuals who have a reasonably foreseeable natural death or would be eligible under the old law versus the number of people that you're seeing because they're now eligible under the new law?
Yeah, it's a difficult question to answer, because there's what's out there and waiting to be seen, and which ones I have actually been able to see already. So it's a bit skewed. I can tell you that in the 6 months or 9 months of data, that we do have nationally from when the law changed, until the end of the year. So from March of 2021 until the end of December 2021, we do see nationally, of all the patients that come through and have MAID, only 2.2% of all of the patients that received MAID were from this track 2, were those whose death was not reasonably foreseeable. So very, very small slice. That was only the first 6 months though, so I expect those numbers will change as time goes on. I can tell you that where I work in British Columbia, where we have quite a bit of people, quite a high number of people requesting and receiving MAID, higher per capita than most places than all places in the country. We do have a growing number of people whose death is not reasonably foreseeable looking to access this care. We don't have sufficient number of clinicians to see all those patients because there's only so many clinicians, and there's a certain sense of urgency for those who are dying reasonably foreseeably. Sometimes those patients get seen sooner. To be perfectly honest, I see that happening. Not necessarily fair, not necessarily the way they should be, but I do see those patients being taken up and into the system a little bit more streamlined, a little bit more willingly by certain clinicians. Myself, I've seen a small handful of those kind of track 2 patients whose death is not reasonably foreseeable. I've helped some of them to die. I've not taken a lot more of them on recently because of my other responsibilities. So for me, it's more like the initial statistics, a very small number. I would say probably under 10%, probably, of those I'm seeing.
Thank you. So a number of people are asking about the changes coming next year in March 2023 when it comes to MAID for people with mental disorders. And the questions are kind of varied. People are wondering different things about it, but generally people are wondering what do we expect? You know, what do we think eligibility will look like?
Good.
You know, how are you feeling about that?
Let's talk.
Yes,
Mental health and MAID, discuss. Yeah. Well, I think what's really important to know is that some context is important. Neither the Carter decision, the Supreme Court decision, nor the original MAID law in C-14, they never, ever excluded any patients from accessing MAID based on their diagnosis. So it wasn't because you had dementia that you couldn't access MAID. It wasn't because you had a mental health disorder that you couldn't access MAID. Everybody and anybody could try to access MAID, but they needed to meet all the eligibility criteria and safeguards. And if they couldn't, then they couldn't have MAID. And it turns out that because it's such a rigorous system, pretty much anyone whose sole and only underlying condition was mental health disorder probably couldn't get through most of that, because for a very long time, you needed to have a death that was reasonably foreseeable, and most of those patients didn't qualify for that. So I think it's important to understand that no one was ever excluded before 2021. It's also really important to understand that there are many people that have mental health disorders, and many of them have concurrent physical health disorders. So we have been seeing for 6 years patients with mental health disorders who are accessing MAID due to other reasons, right? They also get pancreatic cancer. So we have experience assessing these patients, working with these patients, assessing their capacity to make this decision, assessing whether they're being coerced, assessing their vulnerability, teasing out their mental state and whether their mental health disorder is impacting this decision or not. It's not like we've never worked with patients with mental health disorders. I think that's really important to keep in mind. However, currently, it's excluded if that's your only and sole underlying condition. And in March of 2023, that exclusion will expire, and someone whose sole underlying condition is a mental health disorder will have clear access to MAID. And that will be different than anything we've ever really experienced, because before they've either not been able to get through the system or they've had another physical illness that has brought us to help them. So this will be different, and it will be challenging. I'm not going to lie to you. It will be challenging for a number of reasons. There is lack of consensus, for example, in the psychiatric community about whether you could ever say someone with a mental health disorder is incurable, irremediable. And the law requires the patient to have an incurable illness. So if we can't say it's incurable, then they can't access MAID. And there's a split in the community. Some people believe, some experts believe that you can say that, and others don't. So that lack of consensus makes us all a little bit concerned. We don't always have the answers. We have experience from other jurisdictions around the world where this exists, where this possibility exists, where they already have experience helping those with sole mental health disorders to access assisted dying. We will learn from them. We will ask for their expertise. We will have to go carefully and cautiously, like we did in 2016 when we first started and didn't know a lot, like we did in 2021 when we first opened the doors to those for track 2 whose death is not reasonably foreseeable. We're still learning about that. This is a special segment of that population. We're going to move cautiously and carefully. And I think that many patients who will try to access MAID through this route may not be successful. It will be complicated. So we'll have to see. I think the numbers will be small. Check back in a year. Ask me again how it's going. There's only so much I can say at this point. We don't know. I think it's also important to say that, as I can tell right now, as it seems to be happening, there will be no change in the law in March 2023. We already know that this exclusion will part, but there's not going to be extra safeguards or extra things added to the law. There may be practice guidelines that come out that suggest certain standards of care, and I think that's probably wise in the beginning. But the federal law itself isn't expected to actually change and add new implemented safeguards at this point.
Thank you. And yeah, there's a number of groups and individuals looking at recommendations for how things will play out. So it's I think it's important for everyone to know that that's been being studied over the
Being looked
several
at.
months. It's being looked at, absolutely. And there's reports that you can read online if anyone's interested. The final report of the expert panel on MAID and mental illness is one that, folks who do want to take a bit of a deeper dive into what recommendations are looking like can refer to that as well. But as Stefanie said, we're waiting to see what comes out of the next couple months. So we had another question, and you mentioned this at the beginning of your answer to the previous question about mental disorders, but you mentioned Alzheimer's. And another question that we get a lot of, and that is coming up again in this space, is about people with capacity eroding conditions such as Alzheimer's and dementia, and how eligibility works for them, what track 1 or 2, reasonably foreseeable natural death or not, they might be on. So any comments you have about how you've been supporting with people with dementia or Alzheimer's?
Yeah, I have a particular interest in this, so I appreciate the question, and I think it's a whole deep dive in and of itself, like mental health is. So I'm going to try to just contextualize and kind of outline the fundamentals, I would say. So just like I said before, there's no patient population that was ever explicitly excluded from MAID until 2021 for mental health patients. Dementia patients have always had the ability to apply for MAID. It's always been a challenge to figure out whether they could ever be eligible or not. So I would say that in the early days, as clinicians were extremely cautious and unsure of what the law exactly meant and how to apply it and see if people had met those criteria, there was a lot of pushing away of patients with dementia. We didn't really know what to do or how to act. I think we've had a lot of experience now in 6 years. We have a much better understanding of what the law says and how to determine when patients meet those criteria. And it's been clear to me since 2017 that patients with dementia can, in fact, access MAID. Not all, but some patients can. It's certainly not explicitly excluded. And some patients who want to access MAID can apply to do so. And I have helped some of them do that under the original law, under C14, and continuing to do so under C7. The fact that we're able to do so under C14 highlights the fact for me that when a patient is given a diagnosis of dementia, say Alzheimer's, in my medical opinion, and that of the majority of the clinicians that do this work in this country, that diagnosis means the patient is on a clear trajectory towards their end of life, that their death is reasonably foreseeable. And we put those patients on to track 1. They were under track 1 under C14, where they had to be, death had to be reasonably foreseeable. And I don't see any reason why that would change just because the law allows for a track 2. So I personally see these patients and put them on track 1. In order to qualify for MAID with dementia, the two things, the tension comes in maintaining your capacity to make this decision. You have to have the ability to give consent. And at the same time, you have to be in an advanced state of decline, as we talked about earlier. And how can both of those be true at the same time is the question. Can a patient who's in an advanced state of decline with their dementia still have capacity to give consent? And for many patients, you can't. For many patients, it's not possible. But there are patients where both can exist at the same time. And I'm not going to go into the details of how we do that assessment and what we do as clinicians to do so. There are national guidelines from CAMAP on how to assess capacity in patients. There are national guidelines on how to deal with dementia patients who are applying for MAID. There are models of care to do this. Some patients can and do qualify for MAID and receive it. Others do not. I'd say you need to have an experienced provider. And there are a growing number of them out there who will be willing to do this. But just to be clear, the bottom line is it is possible. It is not simple. There's an excellent CBC radio documentary about a patient with Lewy body dementia who went through this process with myself and his wife and I. We did a documentary on CBC. Patient's name, I'm allowed to use, it's very public. His name is Gail Garlock. And if you just Google Garlock CBC, you'll pull up that half-an-hour radio documentary, which goes into more detail about how this model of care works and how it's possible. So I might just leave that there.
Thank you. Yeah, I think that was really helpful for our audience as well. And I know dementia and Alzheimer's, questions about eligibility come up all the time, and we try to add resources to our website, and we've had some webinars committed exclusively to dementia, Alzheimer's, capacity, and MAID, and what it all means and how it all intersects. So audience members, if you want to check our website as well, we have some
good
other
webinars, yeah.
There, yeah.
Deeper dive.
So I think we have time for 2, maybe 3 more questions. So this one is about family doctors. So if somebody goes to their family doctor and they just don't want to talk about MAID at all, conversation is not going anywhere, it's getting shut down. What happens in that situation? What would you recommend that a person do who's in that?
So patients, that's obviously an unfortunate situation. A clinician's personal value system should never interfere with their professional work, in my opinion, and I have strong opinions about that happening. But it does happen from time to time, and so be it, it's life. Patients should know, people should know, you don't need to be referred for MAID or to get MAID information. You can self-refer to a clinician in your area that you know does this work. You can self-refer to a care coordination, a MAID program, a MAID care coordination program in your area. You can go online and look for those resources and call them directly yourself. You do not need your primary care clinician to agree with you. Hopefully they would lead you to those resources, but if they're unwilling to do so, then the answer is to educate yourself and find those resources, or ask trusted loved ones to help you do so. Dying with Dignity can help you find resources. CAMAP can help you find resources. Your local MAID program can help you find resources. Online government sites will give general information about the assisted dying programs. Virtual Hospice gives overviews. I have a website that talks about this work. It's fairly accessible to anyone who's eager to find out the information. So I would say respectfully withdraw from the conversation that's not going anywhere with your primary care clinician, and seek out the information on your own. It is available. It shouldn't be hard to find. You can self-refer, and there's many organizations that will help you get the information you need so you can decide if it's information you want to follow through on or not.
Thank you. So somebody's asking about being able to pre-arrange MAID, to have MAID at a later date. So this person is speaking about, what if I have a debilitating stroke and I'm unable to go through the MAID process because of that stroke? Could I do something now to ensure that I could still have MAID at that point? Any comments?
Yeah, so to be crystal clear about this, what this really is a request for what we call an advance request, where you say, either I have a diagnosis, and if something terrible happens in the future, I would want an assisted death. If A and B and C are true, please help me. That's an advance request. Or even, well, I'm fine now, but if I have a debilitating stroke, I would want that. Both of those are a form of an advanced request. That is not currently legal in this country. It is being debated at a national level. I personally believe we will probably see that type of possibility, an advanced request coming to this country. I don't know if it's in 1 year or 10 years or somewhere in between. I expect we're going to see that because patients and the Canadian public very strongly want that opportunity. They've consistently over the years said that loudly in consistent polls, and I think it's the #1 issue on many people's minds. I do think we'll see that, but that's not currently available. What is available are it's called different things in different provinces. It might be called an advanced directive. It might be called a healthcare planning, but patients can very much speak for themselves for future situations in every circumstance except for MAID. So you can say, if I'm found in situation A, B, and C, this is what I would want. I would not want to be kept alive. I would not want resuscitative events. I would not want to be taken to the ICU. Or maybe you do. I would want antibiotics if I got pneumonia, but I wouldn't want to be intubated if I couldn't breathe. Like you can specify in your own words, in your own voice now, what isn't acceptable to you, and put it on paper and discuss it with loved ones and tell it to your lawyer. And hopefully those wishes would be respected. If you have the right person to whip it out of their pocket and show the healthcare team, those advanced plans can be respected. The only thing you can't plan for in advance is an actual assisted death. The law does not allow for that. That is an advance request for MAID. That's not currently allowed. So there is that separation, but there is a lot you can do already outside of MAID to plan for. And I know Dying with Dignity has toolkits to help people go through that paperwork and to think about what's important to them and what kinds of situations they'd want to be able to speak for themselves for. So I would encourage you to look at those and to speak honestly to yourself about what's important to you, and to speak to trusted loved ones about your decisions about that so they can help fulfill your wishes for you.
Thank you. So somebody has a bit of a procedural question about timing. How long does it typically take from beginning to end during the assessment for MAID? So I call you today and I'm interested in having an assisted death. What will the next few days, weeks look like for me?
So it's different in every case. There's no average. There's no specific, there's no typical, because no case is typical and no case is average, and every case is individual. So I'll be a little bit flippant and tell you the quickest I've ever done this is on the same day. I met a patient, assessed them, got the other assessment, choreographed the death, and provided the scheduled death on the same day. That is extremely rare, not recommended, very, very uncommon, but possible. The longest I've ever had a patient in my practice, from the time they called me and wanted to be involved to the time that I actually provided an assisted, I mean, I have people who are still continuing to be assessed that I've actually provided assisted death, I think is somewhere in the 2.5, maybe 3-year range, because they came to me very early and there was much to happen in between. So, those are really extremes. If you look at local data and things, typically people whose death is reasonably foreseeable will get involved, will speak out, will make a request, and will have an assisted death, often within maybe 30 days, certainly within 90, but often within 30, because they're already at that place. Track 2 patients whose deaths are not reasonably foreseeable, there's a mandatory 90-day assessment period, and I find that that's quite short, that these cases are complicated and often take 6, 8, 10, 12 months to assess. So those cases are probably going to be more in the year mark, I would say, on average, and we'll get that data over the next couple of years. So there's quite a variety. What's important is the process needs to be followed, however quickly or slowly that takes. Patient needs to make a request, assessments need to be done, secondary assessments need to be done, options need to be offered. We're going to try our best to reduce suffering in other ways. That can take a short period of time, that can take a long period of time. There's no average.
Yeah, and what I'm hearing, and I think it's been a bit of a theme throughout many of our questions and answers today, is every situation is different, every person is different, everybody has different needs, and although there's the law in place and it needs to be followed, there's also, what if there's family things that you're also working through with that patient? What if there's a hospital barrier that you're working with and somebody needs to be transferred out? There's always considering those unique factors that you can't always know.
What if you can't find a clinician? Yeah, there's lots of issues. It goes both ways. If something's urgent, we try to act urgently, but we can't always. So like you say, lots of variety.
Well, we're almost out of time. Thank you so much to everybody who submitted questions. Like Melissa said at the beginning, if we didn't get to your question and you do have something that's more navigation or information based, please email us and we'll try to get you the resources that you're looking for. Stefanie, thank you so much for joining us this afternoon. It's always great to have you. And I think everybody getting a lot of lovely comments coming through, thanking you for everything that you shared with us this afternoon.
My pleasure. Good information is important.
Absolutely. We do have a few more webinars coming up this month. So if folks want to register, do check our website and the links will be provided there. And thanks again, everyone. Have a great afternoon.
Take care.